Airway anatomy for the bronchoscopist. Objective: to identify normal anatomy, key landmarks, and common pathologies observed during bronchoscopy, from the nares to the glottis in the upper airway, and from the trachea to the conducting bronchi in the lower airway. Introduction. Bronchoscopy is a technique for visualizing the inside of the airways using flexible fiber optic instruments. In adults, it is often used for biopsy and sampling. In children, it may be used to remove inhaled foreign bodies. Expert knowledge of airway anatomy is essential for safe and effective performance of the procedure. The FB is introduced by the bronchoscopist standing either behind the head of the supine patient or facing the patient. The anatomic orientation of airways varies depending on the operator's position. The anatomical orientation is presented with the operator standing behind the supine patient. Airway anatomy for the bronchoscopist in Introduction to Bronchoscopy, Cambridge University Press. Upper airway, nasopharynx. Examination begins with a quick inspection of nasal and oral cavities. When the bronchoscope is introduced through the nose, the inferior turbinate is seen laterally, and the nasal septum medially. The operator assesses for septal deviation, turbinate hypertrophy, polyps, and mucosal integrity. The bronchoscope is then directed posteriorly into the pharynx. When viewing the nasal cavity, the bronchoscopist should assess for septal deviation, hypertrophy of turbinates, presence of polyps, and integrity of mucosa. Oropharynx and hyperpharynx. When the FB is introduced orally, it passes through the oropharynx and larynx and into the trachea. Beyond the base of the tongue, the bronchoscope is passed through the curvature of the oropharynx, which is bordered superiorly by the soft palate and extends to the tip of the epiglottis. The FB is then directed posterior to the tip of the epiglottis. On this picture we can see left vocal cord palsy and right vocal cord palsy. Pressure ulceration of both the vocal cords due to prolonged intubation. TVC, true vocal cord, polyp, a smooth, pink, pedunculated lesion of the anterior right vocal cord. Laryngeal anatomy. The larynx lies anterior to C4, C5, and C6 and is composed of 9 articulating cartilages, 3 of which are paired, arytenoid, corniculate and cuneiform cartilages, and 3 of which are unpaired, thyroid, cricoid and epiglottic cartilages. Laryngeal anatomy. The epiglottic cartilage overhangs the laryngeal inlet like a door. Thyrohyoid, cricothyroid and cricotracheal ligaments or membrane stabilize and connect the cricoid and thyroid cartilages. Laryngeal anatomy. The triangular fissure between the vocal cords is known as the glottic opening. The space between the base of the tongue and the anterior surface of the epiglottis on either side constitutes the vallecula. The valleculae are separated by the median glossoepiglottic fold and bordered laterally on either side by the lateral glossoepiglottic folds. Valleculae are often locations for foreign body entrapment and upper airway obstruction. Endoscopic landmark. Anteriorly, one can see the tongue base, vallecula, and epiglottis in most patients. To fully visualize these structures, it may be necessary for the patient to slightly protrude the tongue if he or she suffers from pharyngeal crowding or obesity. The laryngeal surface of the epiglottis leads down to the anterior commissure. At the level of the true vocal cords, however, above the true vocal cords is the vestibule, superiorly bound by the false vocal cords. Subglottic anatomy. The subglottis ends 2 cm below the level of the vocal cords. This corresponds cranially to the inferior margin of the cricoid cartilage, which is the inferior margin of the larynx and forms the only complete cartilage ring in the airway. Subglottic anatomy. The subglottis ends 2 cm below the level of the vocal cords. This corresponds cranially to the inferior margin of the cricoid cartilage, which is the inferior margin of the larynx and forms the only complete cartilage ring in the airway. Length, 9 to 15 cm. Outer diameter, 21 to 27 mm. Internal diameter, 12 to 18 mm. Distance infracricoid carina about 11 cm. Tracheal dimension. Trachea. Average cross-sectional area of the male adult trachea is approximately 2.8 square centimeters. Transverse, lateral, diameter of 25 mm and sagittal, antero-posterior, diameter of 27 mm are the upper limits of normal, males. The lower limit of normal for both transverse and sagittal diameters is about 13 mm in men and 10 mm in women, and has 18 to 22 cartilage rings. The trachea tapers slightly and aims posteriorly as it divides at the carina, at the level of fifth thoracic spine to the left and right main stem bronchi. The horseshoe-shaped tracheal cartilage shapes the anterior part of the trachea, whereas the posterior part of the trachea consists of smooth muscles that joins the ends of the tracheal cartilage. The membranous posterior membrane allows esophageal expansion during deglutition. Contains glands, small arteries, nerves, lymph vessels, and elastic fibers. Trachealis muscle overlies esophageal muscle and epithelium. Starting at the upper trachea, mucosal integrity should be examined, even when there are no gross endobronchial lesions. The presence of extrinsic tracheal deviation and compression due to paratracheal masses should be noted. Normal adult trachea begins at the lower margin of cricoid cartilage and extends 10 to 14 cm in length. 1/3 of the trachea is extrathoracic and 2/3 is intrathoracic. The average diameter is 2.5 cm and is supported anteriorly by 18 to 24 incomplete C-shaped cartilages and posteriorly by the membranous trachealis muscle. Tracheal morphologies. A saber sheath or scabbard trachea is defined as a trachea with excessive transverse narrowing and widened sagittal diameter of the intrathoracic portion of the trachea. This is very different from the C-shaped trachea seen in about 49% of normal adults. The saber sheath trachea has been described in up to 5% of elderly men. Women tend to preserve a round configuration, while men tend to have some sagittal widening and transverse narrowing. Tracheal index, TI, defined as transverse sagittal diameter, 0.6 to 5% of elderly men with COPT. Horseshoe trachea we can see on this picture. Tracheal appearances. We can see normal shape expansion during inhalation, circumferential collapse. Saber sheath dynamic collapse, crescent shape collapse. Intraluminal disease and extrinsic compression. Tumor invading through posterior wall. Tumor invading left and right main bronchi. Narrowing of lower third of trachea. Simple and complex strictures. Example of fixed stricture at previous tracheostomy site. Note partial collapse of anterolateral tracheal wall. Classic triangular shape of stromal stricture. Circumferential web following tracheostomy with tracheal stenosis. Healthy tracheostomy scar is also visible. Tracheal stenosis following tracheostomy. Main carina. The main carina is a keel-shaped structure oriented anteroposteriorly. The main carina is identified as a thin septum separating the right and left main bronchi. It is usually sharp in adults, and its dimensions vary during inhalation and exhalation. Normal carina is sharp with bifurcation of trachea into right main bronchus at 25O to 30O and left main brochus at 45O angle from the midline. View showing carina, right main and right upper lobe bronchial openings. Carina with right and left main bronchus. RMB, right main bronchus, LMB, left main bronchus. Widening of carina due to subcarinal lymph node enlargement in a case of lymphoma. Right bronchial tree. The right main bronchus is approximately 1.5 cm in length and has an internal diameter of 10 to 12 mm. The first branch, the right upper lobe, RUL, bronchus, arises just below the carina, and courses laterally for a distance of 1 to 2 cm before branching into apical, anterior, and posterior segments. Right upper lobe usually branches into the apical, anterior, and posterior segmental bronchi. Apical. Posterior. Right upper lobe. Branching point of the RUL bronchus can be identified as a faint curvilinear density marginating the lateral wall of the right main bronchus. The horizontal course of the RUL bronchus with origins of anterior and posterior segments gives the inverted whale tail appearance. Both anterior and posterior, and their subsegments, can be easily seen. Beyond the RUL bronchus, the right main bronchus becomes the bronchus intermedius, extends approximately 2 to 2.5 centimeters, and divides into right middle lobe and lower lobe bronchi. A cardiac bronchus, a rare congenital anomaly, can be seen arising from the medial wall of the bronchus intermedius before the origin of the superior segmental branch of the right lower lobe. Right middle lobe and right lower lobe. The right middle lobe bronchus arises from the anterolateral wall of the bronchus intermedius and extends anteriorly and laterally for about 1 to 2 centimeters before dividing into medial and lateral segments. The lateral segmental bronchus is visualized over a greater distance, and the medial segment has a more oblique course. Beyond the origin of the superior segment, the right lower lobe divides into anterior, posterior, medial, and lateral segments as seen in flexible bronchoscopy. Left bronchial tree. The left main bronchus is approximately 4.5 centimeters in length and tends to progress posteriorly, inferiorly, and laterally. It divides into left upper and lower lobe bronchi. The upper lobe bronchus is 2 to 3 centimeters long and divides into upper lobe and lingular divisions. The origin of the left upper lobe bronchus forms a sling over which the left main pulmonary artery passes. The upper lobe division divides into apica posterior and anterior segmental bronchi. Upper lobe bronchus. Extend superiorly, the lingular bronchus is about 2 to 3 centimeters in length and divides into superior and inferior segmental bronchi. The superior segment of the left lower lobe bronchus arises immediately on entering into the left lower lobe. The left lower lobe bronchi is approximately 1 centimeters in length and divides into anteromedial, lateral, and posterior basilar segments. Conclusion. Solid knowledge of normal and variations in normal tracheobronchial anatomy is the key for successful bronchoscopy. Composite knowledge of adjacent pulmonary vasculature and mediastinal and other structures will aid in performance of specialized diagnostic and therapeutic bronchoscopic procedures.